And let me introduce the next speaker, Professor Dominique Bremond-Gignac from Paris. And we have a little bit different topic now, posterior segment anomalies we started talking about. And as we know, in the PAX6 mutation, there is even more common foveal hypoplasia than even the absence of iris. So posterior segment anomalies in PAX6 related to congenital aniridia. Professor Gignac, thank you.
Thank you very much, Bogomil. Thank you for this session. Thank you, of course, for the organization, for the Swedish organization, I mean for Ivana and Neil, because it's crazy. The weather is there. So I don't know how we did it, but it's very, 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 very nice. So, and thank you, of course, for Aniridia Europe. So I'm president of the scientific committee, and I see there is really a very, very good impulse for the research and everything, and also for the WAGR Association and ANA Association too. So this talk will be maybe a little technical, but the conclusion is quite simple. That's all. We are scientific also, and so we are doing some very important, studies, but the conclusion could be nice. So we know that aniridia is not only anterior segment dysgenesis, so we know that very well. So that's why posterior segment anomalies in PAX6 related congenital aniridia are important, are relevant to know. And that's why we went to that. So we know, I will not come back to all the features we can find, of course, but you see, we know that foveal hypoplasia and optic disc hypoplasia, but we don't know more than this, and so that's why we did some studies. So just to see, it's a panocular disorder, and we talked yesterday from syndrome or spectrum, but for sure, this is a panocular disorder and associated with systemic disease also. We know it's on the PAX6 gene, as you can see on the 11 chromosome that you can see here. And we know also, we talk sometimes from isolated congenital aniridia because there is nothing else. No other syndrome, but could be sporadic family, and could be also WAGR syndrome or WAGRO with obesity, or Gillespie syndrome. So we analyzed something special, which is very difficult to get, is OCT and angio-OCT. We have three. In this data, we have 394 aniridia patients. We did 271 consecutive patients, and from 2014 to 2018, and the clinical findings were recorded. Because it's important to link the anterior segment anomalies to the posterior segment anomalies. And we had, of course, the genetic results, and I can tell that, and I'm very, very proud to have Sophie Valex working on this topic, because she is really doing a great job. So this method was to explore posterior segment of the eye and to better define findings in congenital aniridia. First study on fovea, and the second study on optic disc. For the first study, we used OCT and OCTA and geography, and for the second one, we used ultra-wide field imaging. So we know that retinal layers, it's quite complicated. I will not detail everything, but just to know that's complicated. One point is a new point. When you observe the fundus, we have a new sign, which is concentric macular rings sign in foveal hypoplasia. I don't know if you see that. It's like, it's annular rings, and when you just look at the water, if you make like something on the drop, and so you see rings. And so this is a special sign of macular or foveal hypoplasia. So it's important because sometimes you have no OCT, but if you observe that, you can tell there is macular hypoplasia. There is some difficulties to do the examination in aniridia patients. Why? Because there is corneal opacity, there is cataract sometimes, there is nystagmus, and the patient needs to fixate, which is difficult, of course. So that's why it's not so easy, of course, to get results on this. So it was interesting to correlate the degree of foveal hypoplasia with BCVA, which is the best visual acuity corrected, and the iris phenotype and PAX6 mutation. So I will not detail that, but you understand the knowledge of the study. So we did also the high quality OCT to record and to have the grading. You have the grading of Thomas and Irene Gottlob on the right. And also we classify the iris hypoplasia. So this first study was on the fovea, using both OCT, classical OCT and OCTA. And of course, OCTA, it's much more difficult to get also because of the nystagmus, because of the fixation. So for hypoplasia, we have 95 patients. We published that with Alejandra Darish, and we found that we had really a very, very low rate of grade 2, grade 1, and normal fovea in PAX6 patients mutated. So the second point is the BCVA, the best corrected visual acuity, were correlated, of course, with the hypoplasia, the grading of the hypoplasia. So you can see here there is repartition of the distribution of the grading of the foveal hypoplasia, and you can see that 73% has a grade 4, the highest grading. Just to look, here you have a very smooth iris defect, and when you look at this iris defect, sometimes the degree was most frequently correlated with the severity, and so 70% of the mild iris phenotype showed severe foveal hypoplasia, which means that sometimes the foveal hypoplasia is more common than iris defect. We have also some complicated related features related to the type of the mutation. And so you see the grade 4, and you see with a different, and you can find that on the paper, of course, so it will be easier for you. So the conclusion for this first study was all PAX6 variants associated with mild defect may be at risk of severe foveal hypoplasia and with poor visual acuity. And really, foveal hypoplasia is the most reliable sign to confirm congenital aniridia diagnosis. PAX6 related, of course. Just see the mother. Just hear the mother, because they told her that she had iris coloboma. And so they tell, come back home, that's okay. So they had no idea of that. And so just look the daughter, and just look here. There is severe foveal hypoplasia, which means that if you have just an iris coloboma, there is no problem, for the visual acuity, but here the visual acuity were very low. So we did also the study for OCT and OCTA among 230 patients, and just to look also complicated, hypoplasia, and we had some control subject, of course, to see. There was 10 of the 18 patients, PAX6 related, and 10 controls. It's always very complicated to get these images. And so we can compare here, and you see the appearance is really completely different. And so the difference, and I will not stay on this because it's a bit complicated, but on the foveal, there is a foveal area. We just calculated the mean vascular density, and it was higher in aniridia patients. But on the parafoveal the area, mean vascular density was lower. It means normally the fovea has no vascular feature. But in this case, that's the difference. There is higher vascular in the fovea central, but there is lower in the parafoveal area. You see here on the fovea. And that's why the paper we published, and so you will find everything here. The second study also, and I try to be on time, it's to explore the optic disc. We know that it could be hypoplasia of the optic disc, but well, that's possible. But is it true? Is it for everyone? Is it different? And so we used the ultra-wide field imaging. And it was to characterize optic disc hypoplasia, and on the ultra-field imaging, and also non-mydriatic retinal photography. And so we just compared the disc diameter and the disc to fovea distance that were measured to have the relative size of the optic disc. Just to look here with this ultra-wide field here. And so you see these large fundus we can have. And this one is nice for children because it's easy and it's quick, and it's why we use that. So there was control here on the left, and you have PAX6 related on the right. So if you just compare, we have for the control, and we see there is differences in between control and PAX6 related congenital aniridia patients. So there is a negative correlation found significant between the grade of the foveal hypoplasia and the mean semi-automated ratio of optic disc. And so you can see here, and you can see when the grade is lower, there is less anomalies. And there is also a significant negative correlation between the peripapillary temporal NFL thickness and the grade of the foveal hypoplasia. So just in conclusion, the disc ratio of the optic disc is significantly reduced in PAX6 related aniridia patients, and it correlates with the severity of foveal hypoplasia. So that's important. And this ratio is really a valuable tool for optic disc hypoplasia assessment in congenital aniridia, and especially when we provide semi-automatically by UWFI. Just to remind that there is a therapeutic education program in France, the first therapeutic program, and you can see how we can just teach and explain to patients or parents how it works. And so in conclusion, these studies confirm the correlation between the grading of foveal hypoplasia on OCT and BCVA in a larger cohort of patients. Additional causes of reducing VA, of course, is nystagmus, anterior segment disorders, amblyopia, strabismus, refractive errors. But the grading of foveal hypoplasia is correlated to low vision for sure, and can help in deciding whether further treatment or investigation are necessary to improve visual acuity. And half of the patients with partial iris had grade 4 foveal hypoplasia. And for the two studies, the most reliable sign is, of course, for PAX6 related is hypoplasia, but also vessels density is higher in a foveal area and lower in parafoveal area in PAX6 related patients, congenital aniridia patients. And regarding the reduced side of the optic disc, it's correlated also with severity of foveal hypoplasia, and can be hypothesized that foveal maldevelopment may impact formation of the optic nerve and the optic disc. So for this clinical study, we are here in the Necker study team, and you can see, if you want to come to Paris, it will be a pleasure to welcome you next time. And this is my team. Thank you very much for your attention.
Thank you, Dominique, for the great talk. And we still have a lot of time for discussion, I think. Yeah, that's great. And you know, our experience with this foveal hypoplasia is that because we have a lot of patients with partial aniridia as well. And sometimes on the beginning there is, for general doctor, there's no problem because they dividing it between the partial aniridia, and even it's a little bit different in the iris. On the beginning, in my opinion, it should be properly done examination of the as soon as possible of the children, and we do it in general anesthesia on the operating room, because then we have time and we could do it properly. And I totally agree that most of them has foveal hypoplasia, but is to be make examination as soon as it's possible to inform the parents that it could be a problem, because not always there is an nystagmus as well. So we need to be really careful with that. And as we know, examination of infants is impossible normally, because I think the youngest aniridia children, we did the examination was 6 weeks, because this is a problem also with our anesthesiologist wants to children over 6 kilos to make the general anesthesia, but I think it should be done as soon as is possible if we have any doubt about iris hypoplasia.
Thank you. I agree with you, Bogumil. So for sure, this is important to have a first management of the whole disease, ocular segment disease, and the posterior also. And so we do it under general anesthesia, as you, and we have also handheld OCT, so we can do the OCT. But as I tell you, it's quite simple now. If you observe annular ring and at the fundus, you can tell the parents that there is foveal hypoplasia. When there is less nystagmus, or where there is no nystagmus, usually the hypoplasia is mild or absent. So.
Neil.
Yes, Neil.
Thanks for the very nice data that you've shown. Is it a selection because you're only able to examine the back of the eyes in the cases where they don't have cataract, where they don't have developed keratopathy? So what do we think or know about those cases in terms of their fovea?
Yeah, that's a very good point. Of course, I couldn't do that for the 420 patients, and that's why we had for the first study, for the OCT studies, it's less. So we have more patients, but of course for the OCTA, it's really it's a real challenge to get images. So we did on the selection without, of course, with a corneal opacification and with not too uncontrolled nystagmus and so. But we did that, so we have answers with that question. But that's nice to say.
Okay.
Hello.
Okay.
Here I'm sitting.
Sorry.
Okay. Berit Byström from Umeå. Thank you for your presentation. I wonder that case you presented, the mother with the iris coloboma. What about her fovea in the other more normal eye and her visual acuity in the other eye with the more normal?
You have seen the OCT. They were the same on both eyes.
They were
same on both eyes.
Okay.
It's very important. Yeah.
And for how long time did she have this diagnosis? I'm thinking about as a clinician.
Yeah.
Shouldn't I have thought about having a non-iris coloboma and still having a fovea that was not? Maybe no one looked there. I don't know.
I can tell you for this lady, she had the diagnosis when she was adult and when she had her daughter.
Okay.
So that was a very long,
Mhm.
long process.
Mm.
So it's not usual, but sometimes it's very long.
Mm.
So we really need to really manage the iris coloboma as it could be something else than a regular iris coloboma, I mean.
Mm.
So OCT is mandatory now. For a clinician, you can do that very easily. But of course, if you have a nystagmus with iris coloboma, you know this is not an iris coloboma. And if you look at what I told you, this is not an iris coloboma just looking at it. Why? Because it's not vertical. So that couldn't be a normal fetal feature anomaly. So we know it's just looking, but I can understand it's not so easy.
But she didn't have nystagmus, this particular case.
No,
No,
they didn't have a large nystagmus.
And the visual
a
acuity
small
in
one, yeah.
the other eye, how bad was it?
I don't remember about the BCVA. I'm sorry, but not too bad. Not too bad. Yeah.
Dominique, thank you for that great talk. I'm going to take the question in a slightly different way. So the first is, with respect to the blood vessel formation, does it have a peripheral retina-like characteristic to it?
Well, that's a good idea also. It's very complicated to know about the peripheral retina because it's very difficult to get OCT in the peripheral retina. So I'm not sure I can answer the question because it needs probably further studies. Just at a looking, we don't see with special signs in the peripheral retina, but it could be different. It could be useful when we will have a larger OCT interpretable, because it's not so easy, in the periphery. And at the time, I can't answer. I don't see, in macroscopy, I can't tell you I see some anomalies, but it could be, I don't know.
And then the related question, which is a little bit broader, what is color vision like in people with aniridia who do not have a fovea?
It depends on the grading, so about the vision. So, but sometimes it's very strange because you can have 410 vision and quite a grade 4 hypoplasia, and I don't know why. I can't answer that. Maybe because the nystagmus is low, but maybe also because the integration in the brain is better. So, and sometimes you have just 120, and I can't really answer to this. But if you just look at the population, everyone that has a good fovea, they don't have the same visual acuity. So I think there is differences we cannot characterize at the time exactly, and I can't answer this way. Thank you. Thank you for the very good questions.
Okay, maybe last question. Yeah, we have.
Thank you very much. Absolutely great talk. Fantastic. And this is like the basic things, what we all should understand about congenital aniridia. And come back to our discussion yesterday, what is aniridia syndrome or spectrum? And then it's some word just like come into my ear, partial aniridia. Should doctors, when they write report, just saying partial missing of iris, because congenital aniridia itself cannot be partial or full. It's just like PAX6 congenital aniridia syndrome, with all this, including hypoplasia of macula, hypoplasia of optic nerve, and then, or it's like full iris missing or part of iris missing, but just when write in report, not write partial aniridia, but partial missing of iris. What do you think?
Okay, so we try to do simple, and that's a good idea, but we need to have some turns very quick, because if we do a longer, it will be very complicated. But I understand what you're saying, it's a good idea. I think we could talk of this a very long time. So we will think of it, and we will try to make a consensus, because the answer is not now, I think. But thank you for the reflection for that. Thank you.
Thank you. We are exactly on time. Thank you for the first session. It was great talk, great discussion.